Hello everyone, my name is MS AMITH, 4th year BAMS student, Bapuji Ayurvedic Medical College. COPD, Chronic Obstructive Pulmonary Disease. Outline, Introduction, Definition, Types, Pathology, Risk Factor, Clinical Features, Diagnosis, Treatment, Complications, and difference between COPD and asthma. Introduction. COPD is the obstruction of airflow that does not change appreciably over a period of several months. In past, COPD was referred as chronic airflow obstruction. In 1965, Dr. William Briscoe was the first person to use the term COPD, chronic obstructive pulmonary disease. COPD is the major cause for morbidity and mortality that affected over 44 million people in 1990. It gradually increased to 250 million in 2016. COPD is the fourth leading cause for death in the United States. In 2020, COPD is the third leading cause for death in United States. More than 90% of COPD death occurs in lower and middle income countries like tobacco chewing, cigarette smoking, BD smoking, smoking weed, usage of solid fuel for cooking and heating, etc. Definition. COPD is a group of lung disease that blocks airflow and make it difficult to breathe. COPD is a disease state characterized by the presence of airflow obstruction caused by chronic bronchitis or emphysema. COPD is a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing, and it is not fully reversible. There are two types. One is chronic bronchitis, another is emphysema. Chronic bronchitis. Bronchitis is literally an inflammation of bronchi. The wall or chronic bronchitis. Bronchitis is literally an inflammation of bronchi. The walls of bronchi inside the lungs become inflamed, and this inflammation decreases the bronchi diameter, so less air able to flow through the normal. So the inflammation process promotes excessive production of mucus, bronchial mucus, which serves to keep the airway clean and free from bacteria produced under normal condition. However, the excessive mucus produced in bacteria in bronchitis is thicker and more difficult to cough up than the normal, and acts to clog the airways and inhibits lung capacity. Emphysema. Emphysema also reduces the efficiency of gas exchange process, only in different manner. Emphysema affects the alveoli, specifically their sensitive membranes through which the gases exchange process occur. Emphysema causes alveolar membrane to lose elasticity, become brittle, and then actual rip and tear. Broken alveolar membrane cannot be regenerated by the body. Each time alveolar membrane bursts, more surface area within the lung necessary for gas transfer is permanently lost. As this process progressive, it becomes very difficult for patient to exhale because their weakened airway threaten collapse the harder they try to breathe out. The heart tries to compensate for the loss of oxygen availability in the bloodstream by pumping harder and faster. This process associated with other problems including heart failure. Pathology. Pathology of airway. Chronic inflammation, increased number of globular cell, mucous gland hyperplasia, narrowing and reduction in the number of small airways, and airway collapse. Pathology of chronic bronchitis. Irritative substance enters respiratory tracts, overactivity of mucus secretion glands and globulate, increase in secretion of mucus. Mucus coats the wall of airways and blocks them. Airway becomes narrow and shows inflammatory changes. Pathology of emphysema. Smoking causes clusters of alveolar. The alveolar membrane loses its elasticity. Walls become weak and collapse on expiration. The increased intra-alveolar pressure leads to break of alveolar. Capillary around the alveolar is also stretched. Risk factor. Cigarette smoking is the main cause for COPD. Second-hand smokers like passive smokers and air pollution, dust or workplace fumes, biomass exposure, example like wood smoke, etc. and alpha-1 antitrypsin deficiency. Clinical features: signs of COPD: barrel-shaped chest, prolonged expiration, expression through pursed lips. Symptoms of COPD: dyspnea, chronic cough, chronic or excessive sputum production, wheezing, chest tightness, weight loss, respiratory infections. Diagnosis: investigations: smoker or have smoked in past, exposure to lung irritants on the job site, family history of COPD, asthma or other respiratory condition, spirometry, blood test, chest X-ray, sputum culture, CT scan, ECG and walk test. Spirometry. Spirometry is a pulmonary function test that measures how much air a person breathes out and how quickly. Pulmonary tests measures how well the lungs are working. It's an office-based diagnostic test that is short, simple and commonly used. Treatment: medications, supportive care, self-care, surgery or transplant. Medications: bronchodilators, medicines that makes breathing easier by relaxing and widening your airways, thereby decreases in airflow obstruction. There are two types of bronchodilators are there. One is short acting, another one is long acting. Short acting. Short acting inhalers should be used when you feel breathlessness up to maximum of 4 times a day. Long acting. Long acting inhalers works in similar way as short acting, but each dose lasts for at least 12 hours. So they only need to be used once or twice a day. Steroids. They help in reducing the inflammation in the airways. Supportive care. Oxygen therapy. Oxygen treatment increases the amount of oxygen that flows into the lungs and bloodstream. If blood oxygen level is low, then by getting more oxygen can help you breathe better and live longer. There are several ways to deliver oxygen: oxygen gas cylinder, oxygen concentrator, liquid oxygen device. Nowadays, oxygen systems are portable. You can use them while doing daily activities. Self-care. Quitting smoking, physical exercise for 20 to 30 minutes 5 days a week, performing yoga and pranayamas, and having a healthy diet. Surgery. Bellactomy. During this procedure, surgeon removes a large abnormal part from the lungs. Or the lung transplant. Transplantation of lung is another option. Complications. Pneumothorax. This condition occurs when air leaks into space between the lungs and the chest wall. Exacerbation of COPD. This condition is a worsening or flare-up of COPD system by infection of lungs, but in some cases the reason is never known. And respiratory failure. A serious condition where the lungs cannot able to get enough oxygen into blood and build up CO2 can also damage the tissues and further leads to severe condition. Comparison between asthma and COPD. Asthma is another respiratory disease that may be associated with COPD, but which is not itself classified as COPD. The people who have asthma have highly sensitive bronchi that are more reactive to environmental irritants like smoke, dust and pollen. During asthma attack, asthma patients' bronchi swollen and narrow in a manner similar as bronchitis, restricting the volume of gases that transfer between blood and air. At this time, relation between asthma and COPD is unclear. Numerous researchers believe that asthmatic people may have genetic vulnerability of COPD. These are the brief information about COPD. I hope it would be helpful for you.